Health centers, we're serving almost 34 million patients at this point, which is incredible.
That's the important part, is that we should care deeply about economic policies because they do make a key impact on every aspect of our patients' lives.
Sometimes with the best of intentions, policies or programs are designed that don't necessarily kind of take into account all of those different factors.
I think that healthcare providers and community health centers are really in the best position to comment on that because they are seeing the patients.
Hi, everybody. Welcome to Community Health Centers Unfiltered. I am Amanda Pierce-Kelly. I'm the CEO of Advocates for Community Health. Today, we're diving into a topic that's central to health, but in a lot of ways overlooked in traditional healthcare, and that's food and nutrition. For many underserved communities, access to nutrition and nutritious food isn't about what's on the table. It's actually a much bigger and much more vital part of managing chronic conditions, supporting mental health, and building healthier futures. So community health centers have been and continue to step up, not just as medical providers, but also in a variety of ways as hubs for nutrition, education, food access, and holistic care. We're going to explore why food matters and the barriers that people face and how health centers are innovating to make sure that those barriers are addressed. We're going to be joined by Dr. Laura Samuel. She's the Associate Professor at Johns Hopkins School of Nursing. Dr. Samuel works on focusing on advancing health equity for low-income individuals and families, exploring how improved access to food reduces food insecurity and leads to better health outcomes. Her passion stems from years as a family nurse practitioner, helping patients meet their basic needs. She's had groundbreaking research funded by the National Institutes of Health and the Robert Wood Johnson Foundation. She sheds light on deep connections between food and health. She's an expert in this space. She's someone we've been thrilled to be able to follow and watch and appreciate, honestly, in terms of bringing visibility to an issue that could not be more important, especially as we focus on how food is medicine and how nutrition plays an absolutely vital role in the bigger picture of health. So with that, let's get started. So hello, I'm Amanda Pierce-Kelly. I'm the CEO of Advocates for Community Health, and this is Community Health Centers Unfiltered. And I'm so excited for our conversation today with Dr. Laura Samuel. She has such an incredible wealth of knowledge, especially when it comes to food insecurity and nutrition and on and on and on. So I'm really excited to start the conversation, but Dr. Samuel, will you introduce yourself and just tell us a little bit about yourself before we get started?
Sure. It's nice to meet you all. So I'm Laura Samuel. I'm an associate professor at the School of Nursing at Johns Hopkins University. I started out my career as a nurse practitioner, so kind of understand that clinical world a little bit. But now I spend my days doing research, looking at things like food insecurity and financial strain, and have a large segment of my research looking at the SNAP program, which is the Supplemental Nutrition Assistance Program, and I focus on its health impact.
So we have so many questions to get through, and I have so much to ask you about. But just to start, can we kind of level set in terms of when we talk, the term food insecurity, I think, has risen in sort of usage and visibility. But can you speak to what do we mean by that and the prevalence in underserved communities in particular? Just level set, sort of 101 for someone who's sort of entering the conversation for the first time.
Yeah, absolutely. So food insecurity is really just the experience of not having enough of a balanced diet consistently, meaning that someone might sometimes go hungry, but they might also have to just kind of compromise in terms of not eating a good diet on a regular basis because they can't afford food. So there's simple ways to screen for food insecurity, questions like whether people worry that their money runs out or whether the money runs out and they can't afford to buy food. It's those types of questions that really capture food insecurity. And in the United States, generally about 12 to 13% of households are food insecure every year. It's something we probably don't talk about enough because there's some amount of stigma around it, but something that is really important to identify for our patients. And there's real noticeable disparities. So people who are low income, especially those living very close to the poverty limit, have about triple the rate of food insecurity compared to high income people. There's also racial disparities. People who are Black, Hispanic, and Native American typically also have food insecurity rates that are about double that of the general population. And there's disparities based on disability. So they also have disproportionately high rates of food insecurity pretty consistently.
It's a travesty for so many different reasons, but I think it's hard to wrap your head around food insecurity in a country like the United States where there is so much. It
Right.
sort of is a baseline of no one should be going hungry, but of course that is the reality. And I know in the health center world, you mentioned the screening questions, like that's a very standard part of, the conversation and the screening questions that happen when patients come in the door as a part of every single appointment, just to make sure, hey, where does this fit in your bigger picture and your whole health? And I want to speak to that, or my next question for you is in that vein. So can you speak a little bit to the impact that food insecurity and nutrition in general has in terms of managing chronic health conditions, chronic diseases like diabetes, hypertension, obesity, you name it?
Yeah, absolutely. So people who are food insecure do have a higher risk of developing obesity and other metabolic conditions like diabetes. And part of the challenge is that there's also a correlation with, other types of financial hardships in the households, right? So if people don't have sufficient money to put food on the table, they probably actually also don't have sufficient money to afford their medications on a regular basis or see their healthcare provider for preventive services or routine screenings. And so people who have food insecurity also tend to have undiagnosed chronic conditions, right? They're not seeing their healthcare provider on a regular basis. Their diabetes might not go, kind of detected and diagnosed. They may not get in for treatment in a timely fashion for established conditions. And so they have a disproportionately high risk of having complications. People with diabetes and food insecurity also have higher risks of having a stroke or heart attack because they're not getting treated in the way that they should, and they really struggle to have glycemic control, for example. And same is true for many other chronic conditions for people with food insecurity, that it really impacts them not just because of the food insecurity, but also because of the underlying financial struggles that led them to be food insecure and influences their life in other ways.
I was going to say, I think that's the other thing that's striking about this conversation and so unfortunate and sad. It's the way that this part of the picture impacts so many other parts of your life. And I know, health centers, we're serving almost 34 million patients at this point, which is incredible. But I know there's, and if you then take into account 90% of those patients are at or below 200% of federal poverty. So you're talking about folks who are living in that space and that reality, many of them that you were just speaking to. And I think, whether it's parents, a single parent, or parents, plural, that are trying to make sure that their kids are taken care of first, and then the impact that has on them if they don't have enough for themselves. What does that look like in terms of trying to perform or even hold down a job? I also think about it for kids. How do you focus in school if you don't have adequate nutrition? And I think there's programs that I know we're going to talk more about that sort of really speak to and try to address this. But before we even get there, the mental health connection between nutrition and food insecurity, speak to that a little bit, because I think, there's the medical sort of, it's a different part of the clinical equation that I think maybe is more obvious to people, but I think there's a really big connection here on the mental health side. So can you speak to that a little bit?
Yeah, absolutely. No, I'm glad that you brought that up. I think as as clinicians, we often do think about kind of the underlying physiology of, say, hunger, or maybe like, nutrition or lack of nutrition. Those obviously have implications for people's health, but the kind of mental health impact is less visible and sometimes harder to quantify. But it's meaningful in that financial strain and food insecurity are very stressful conditions, right? Like people are really struggling to make ends meet. And they live with that stress, especially like think about the parent situation that you just mentioned of like, feeling that pressure to ensure that your child can have a healthy meal and can perform well in school, we know that that really sets them up for their lifelong trajectory, right? In terms of their academic success, their economic opportunities, their social relationships, their behavioral patterns. And so food insecurity is really integral to health, and it does definitely impact people's mental health. There's a much higher risk for having depression or anxiety and greater symptom burden, meaning that it's just kind of like more severe for people with food insecurity as well. And so really the physical impact and the mental health impact are substantial, and that's, kind of over the lifespan accumulate in meaningful ways. And, one study showed that kind of middle-aged and older adults who are food insecure have functional limitations that are comparable to those who are 14 years older than them, meaning that they're just kind of aging at a more rapid pace. And some of that is probably due to that kind of like underlying wear and tear in terms of the stress and the way that that impacts the body over time.
So then I think the other thing that strikes me is that there's food insecurity, and then there's access to healthy food. And sometimes they're linked, but I think it's important. Like, I'd love to hone in on that. That's one thing. And then the other reality that I'd love for you to speak to, and I may chime in too, but is the reality for underserved populations, and sort of what does it look like in terms of literal barriers to accessing healthy food in general in some cases, which often that's economic. But then there's another layer, which is, okay, if you can figure out how to find the resources to access food, so the insecurity component might maybe be addressed in a way, but if you can't access healthy food, there are major issues and damages and clinical realities that come from that. So can you speak to that a little bit in terms of what it looks like for underserved populations and communities? What are the barriers there, but also kind of drawing that or connecting the dots between food insecurity and healthy food nutrition?
Yeah, no, that's a great question, because some of it are the kind of economic drivers that lead to food insecurity, but part of it is just the way that our kind of neighborhoods are set up. In that low-income neighborhoods tend to have fewer kind of supermarkets and grocery stores that provide, fresh produce and whole grain breads and the kind of healthy food items that people really need to maintain their health. There's similar findings in terms of residential racial segregation, in that neighborhoods that are predominantly Black or have a kind of a higher percent of Black residents also have poorer access to the same type of grocery stores and supermarkets. So there's a real kind of geographic pattern in terms of the distribution of food resources in the United States. And that means that there are kind of big swaths of our country, especially in low-income areas or in predominantly Black communities, that are food deserts, meaning they don't have any grocery store within a kind of easily accessible distance. And then you compound that with the way that other resources in our communities are similarly kind of clustered or spaced, right? So like you need a bus to get to the grocery store, and many communities that don't have grocery stores also don't have good kind of metro bus train service, right? And so you're talking about the very same communities that are struggling in both ways and don't have the economic resources to just buy a car and get to the store. And so that's another real challenge. It contributes to higher food costs in some communities where, the kind of money that you would earn or maybe money you get from SNAP benefits just doesn't go as far in certain communities, because the overall cost of getting the transportation to the grocery store, buying the food off the shelves, getting it home and cooking it, that's, substantially different cost in one neighborhood versus another.
Yeah. Well,
so that can really make a big difference.
Yeah, and then I think when I then connect that to chronic disease, particularly to diabetes, it's sort of, I'm just imagining some of our patients where, again, I'm going to use this sort of like, okay, you've got a parent who's doing the best that they can to make sure that whatever resources they have and supports that they have, they're doing the best for their kids. But that doesn't, often what I have, anecdotally seen and heard, and the conversations that I've had with patients over the years is, they're trying to stretch that as long and as far as they possibly can. And so right, wrong, sad, doesn't matter. The reality is that, okay, if you're trying to stretch the dollar as far as it can go, a lot of time the quality of that food is going to be lower, because fresh produce costs more, and some of the healthier options for foods cost more. So if you're limited and you've got to make a choice, okay, how do I stretch this for the entire week or longer than that? And you have multiple mouths to feed, and you're also, to your point, whether you're facing transportation barriers or, childcare challenges or whatever the case may be, there's just a lot of realities that contribute to what it looks like to make choices you might want to versus what you have to deal with. And then again, kind of bringing it back to the diabetes equation, if I think about a mom who herself is living with that chronic condition and she's doing her best, but her first priority is going to be her kids. And so again, then she's making choices to take care of her kids, but not necessarily the best choice for her health specifically. It just gets really complex, and there's not, this is not a new issue. Maybe that's a good segue into some of the programs that exist that are really important in sort of addressing this, SNAP being one. But if it was a simple solution, I think we would have already checked that box, and we haven't. So obviously we have a lot of work to do yet. But do tell us about SNAP, sort of what is the program, a little bit of history, sort of where we are right now, because it's, that's a vitally important program when we think about this bigger picture to the conversation.
Yeah, absolutely. SNAP is the largest food assistance program in the United States. It typically provides food assistance for about 40 million people each year. And it is really focused on low-income households. So based on the federal guidelines, households that are about 130% of the poverty limit or less can qualify for SNAP. Some states can expand the eligibility using certain flexibilities, a little bit up to about 200% of the poverty limit, but we're really talking about overall a very low-income group of people who have disproportionately high rates of food insecurity. So as I mentioned earlier, these are about triple that of the rest of the population. So it's really focused on addressing that unmet need in terms of food access. And it simply provides people with money on an EBT card, kind of like a debit card that you can take to the grocery store and buy foods. There are some limitations in terms of what you can buy. You can't buy prepared foods generally with it. And it's intended to kind of supplement the household food budget. So it's not going to provide the entirety of what a household would need, but it can be a substantial kind of stopgap for many low-income households. And we know that SNAP actually plays a key role in addressing food insecurity. It's been shown to be kind of an anti-poverty program, meaning that it's enough to lift some households just above the poverty limit. And it reduces food insecurity by about as much as 30% for low-income households. So that's not a trivial amount. It makes a big difference for these households in terms of ensuring that they can put food on the table.
Yeah. Can we talk about stigma a little bit? So I grew up in Maine. And
me too.
Oh, you did? I didn't know that. Well, see, we have all these things in common, Laura. So then you'll get this. Okay, so when I have been saying this a lot lately, probably partly because I'm still in disbelief that it's 20 years that I've been working with health centers this year. But when I first started in 2005, I was in Maine, and my work at that time had me primarily working in the Northeast. But because I was from Maine, and about half of my time was working in grassroots advocacy, and half of my time was doing policy work in Maine for health centers. But I remember traveling around my home state and encountering wonderful people, lots of health center patients, but really wonderful people who were receiving their care at health centers. And the health center, in part, was trying to connect them with resources, whether that was Maine Care or Medicaid, or it was programs like SNAP. And I will never forget a couple of different patients who I encountered, and honestly, there have been many more every year and in every place since, but there was an enormous stigma and like an embarrassment and such pain in needing that support. And it literally even now makes me emotional thinking about it, because I just remember thinking, my gosh, like this is the program literally exists to support people like you. And in some cases, in talking with the health center at the time, especially, people would decline it because there was so much stigma. They didn't want to take the help. And so it takes a lot of humility to be able to get to a point for some people to be able to leverage these programs. But that stigma exists in that particular way where, someone is just feels so much pain over needing that kind of help. I think there's stigma around, oh gosh, judgment from others in your community or in your surrounding area, whatever it happens to be. And I think that unfortunately, sometimes that is a barrier that we see. So I mean, it's been 20 years of doing this, but you've been much closer to the work, and sort of, I'm curious sort of where things are from your perspective on that. Have there been any, specific initiatives or strides in that space, or what do we do to combat the stigma? Because I think, unfortunately, the need is not decreasing. If anything, I think right now it's increasing. So if we can at least try to address the stigma, to connect people with the resources and the supports that they have available to them, I think that's a big part of this equation too. But any thoughts on that?
Yeah, no, I'm so glad you brought that up. And you're right that the need is increasing. Rates of food insecurity have actually risen since 2022 in the United States. And that I think it's really challenging. I think that the stigma is really a social problem, in that we have a society that has this whole narrative around the fact that people can pull themselves up by their bootstraps, right? And that we often make false assumptions about people who are struggling with food insecurity. We assume that they must have done something wrong, or that perhaps they don't know how to manage their money if they're in that position. But in reality, when I've talked to, low-income adults doing qualitative research time and time again, I would hear them say things like, I just, I worked all my life, but there were many years I just wasn't making any money, right? Yeah. I think that we have to realize as a society that we are not actually providing many people with a livable wage. The U.S. federal minimum wage right now is $7.25 an hour. That means that people can be working full time and still be below the poverty limit, right? That's a shocking, I think, piece of information that most people don't think about, is that many people who are on SNAP are working. There's a lot of conversation right now about work requirements for SNAP. I think we assume that people receiving SNAP and other benefits like Medicaid are not employed, but that's not factually accurate. There's many people who are working but still need essential benefits like SNAP and Medicaid, because we don't provide a livable wage for many jobs. And we don't provide sufficient kind of economic stability, especially in the modern kind of gig economy. There's so many people who don't have job stability or a continuous source of income that they know they can count on, right? I grew up in Maine too, and there's a lot of seasonal jobs in many parts of our country. And so those are not going to sustain you throughout the year to ensure that you can stay food secure. And so I think that part of it is that we have to realize that our economy is not set up in a way that allows people to have the economic stability that they need to really provide for their families. And we can only really address the stigma when we as a society come to terms with the fact that it's a structural problem, not the fault of an individual who's experiencing it.
Well, and I want to get into that was one of the questions, is sort of the systemic realities, the systemic issues like economic disparities that kind of exist in food insecurity. But I also want to just say, and I have to ask, so where are you from in Maine?
I grew up mostly in Kennebunk.
Oh my gosh. Okay, we're neighbors. I grew up right outside of Portland, mostly. But but what I was going to say is I think about the reality, especially in the northern part of the state. But honestly, it's Maine. It could be Nebraska. It could be Alaska. It could be New Mexico. It doesn't matter. But I bring it up because I think there are so many different layers to this conversation, and one is rural, right? So to your point, where I think there are assumptions made at times about people who are receiving benefits, whether it's SNAP or Medicaid or whatever the case may be. But if I think about, some folks in my own family, they have to drive, in some cases, 45 minutes to an hour to get to their job. So then you think about gas right now, the cost of gas, and maintaining a vehicle. And then everything else that goes along with life. And sort of, you mentioned this earlier, like where and how do you access healthy food? You know, how close is the grocery store? You know, what can you access when you're in that store? And I think about a lot of the communities particularly in rural Maine, where, you know, it's the same store. You've got to drive quite a distance to get to a major grocery store. Otherwise, you know, you're probably looking at Dollar General or convenience stores or kind of a smaller market that is going to get you at least part of the way, but not necessarily the access that you need to be able to gain the security that we're all talking about. But can you talk about that a little bit more? Because I think this does look a little bit different in rural America. I mean, I don't want to detract from the reality across the board, but like, can you reflect on that a little bit?
Yeah, absolutely. I'm glad you asked. I think that we do have an assumption that the majority of people using benefits like SNAP are urban, but actually they're more likely to live in rural areas.
Yep.
And I think that there are just kind of qualitative differences, meaning that you can't, like, urban food access isn't somehow worse or better than a rural food access. They're just entirely different beasts.
Yeah.
That we actually have a lot of research looking at urban food environments. I think on average we have less research looking at rural food environments and really understanding how people are accessing food or how we could try to intervene to improve food access in rural America. And so I think that really is a gap in that there's much less research. That means there's like a smaller evidence base when we're trying to develop effective programs and policies that will really address the specific food needs for rural America. But it is a different beast. Distance is certainly a key role. I think we also assume that because rural America has more farms, that somehow there's like food access there, and that is factually not accurate based on our current food systems, right? That food is getting shipped elsewhere. Yep. And so, being close to a farm does not improve your food access necessarily in any way in the United States because of the way our food subsidies and food systems work out. Yep. And so rural America does have unique challenges. This is particularly true, I think, for older adults. Yep. Who don't drive anymore, because driving is essential for really food access, but also healthcare access. If you think about it, like, you have to drive everywhere. And a lot of rural America doesn't have kind of like transit support systems in place. And so that also plays a key role in terms of ensuring that people have food access. And you just need a different set of strategies to address rural versus urban areas.
Yeah, it's interesting. I was just with a group of health center CEOs yesterday, and one wonderful CEO from Kentucky mentioned, and we were talking about, something very similar, but she made the comment, she said, look, Instacart doesn't exist in my community. It's not like, someone, if they have the resources, can order food and have it, arrive at their doorstep. That doesn't exist. And so, again, I think the misnomer is, what is sort of in your immediate space. And there's no fault to anyone, but if you don't necessarily have the opportunity to go out and see and observe, it exists differently in another space, I think sometimes with the best of intentions, policies or programs are designed that don't necessarily kind of take into account all of those different factors. The other thing that I was thinking about, Laura, that this is, kind of taking us in a different direction, but there's an education component to this too. And I was thinking about kids in particular. I have a 12-year-old and I like to think that he's pretty up to speed on, healthy food and nutrition. He has a lot to learn, and also he never stops eating because he's 12. But aren't we privileged to be in that position? But I think the education around healthy food, and honestly, just we also happen to the comment you made, sort of our food system right now carries a lot of processed foods, and so people don't necessarily even know how to determine healthy versus unhealthy. And I think a lot of that starts with our kids. But could you speak to that a little bit in terms of like where are the educational elements that exist in this space? How does that or doesn't it tie to SNAP, or, where have you seen strides in that space, and where are there opportunities? Because I think when I consider some of the focus and the initiatives right now, sort of in Washington, D.C. and elsewhere, in an effort to sort of really lean into nutrition and healthy food and address food insecurity, I hope. But I think education has to be a part of that. So can you speak to that a little?
Yeah, absolutely. And I think, nutrition education plays an essential role, that there's evidence, for example, that SNAP can reduce food insecurity. We don't have the same body of evidence to say that it can improve someone's dietary quality. Mm-hmm. And part of that is the nutrition and kind of education gap in terms of the fact that most people will prepare the foods that they have prepared their whole life, or maybe what their parents prepared, what's easily accessible or what they're comfortable with, right, in terms of having comfort foods. And so, we do need a formal kind of educational component to come alongside programs like SNAP. WIC is one example where they integrate that a little bit in terms of providing food, but also teaching parents about healthy nutrition for themselves as well as their kids, to get kids off to a good start in life. There's also an essential program right now called SNAP Ed that really is in the crosshairs of the current federal government. Many states are winding down their current SNAP Ed programs, even though these are programs that provide essential services to low-income families. So, for example, many of them partner with Head Start programs in their community. Mm-hmm. We're talking about very young kids or families who really rely on that as a source of nutrition guidance. And as you know, rates of chronic conditions are increasing nationally. And there's a whole, MAHA movement to address chronic conditions. But at the same time, SNAP Ed funding has been slashed. Even in my own state of Maryland, the SNAP Ed program has been announced. They anticipate ending in October. And many other states are winding down their programs right now, just at a time when we should be doing more to address chronic conditions that are related to nutrition and metabolic conditions. So there really is a huge need right now for improving and strengthening nutrition education for low-income families in particular.
Yeah, so this is one, it's interesting because I have so much appreciation and I guess I'm very proud of health centers because this is a space where they actually have really stepped up. And I think, their model supports this by virtue of having sort of your 51% consumer majority board. Your community is helping to inform the way you're designing certain components of your program and your care and so forth. But again, just sort of having the opportunity to sit with the CEOs I was with yesterday, we talked about this and sort of how nutrition education and cooking classes and access to healthy foods and all of the things that sort of surround this space and what health centers have done. Each of them have designed sort of different programs based on the needs of their community. And it's everything from, creating community-based groups. Sometimes it is attached, oftentimes it is attached to chronic disease management, specifically diabetes, but it's to help them help their patients learn and their community learn, what does cooking healthy foods look like? How are you making good choices when you're going to the grocery store with whatever limitations or resources that you need to leverage? And same thing for kids, like starting at a younger age. But there are some incredible models across the health center space that I think in a lot of ways have been born out of necessity because, to your point, like there are not necessarily federal or even state-based programs that are far-reaching enough to get at what's actually needed in the community. But I'm curious, because this is your body of work and research, are there any sort of models or examples that you know of in the health center space that really kind of stand out to you or that you would kind of flag as, this is a great example of something that's worked well?
Yeah, I think that's a great question. And I want to kind of, commend so many health centers and that I think that that they excel at being problem solvers and coming up with creative solutions. And I think this is a space in which there's not necessarily a one-size-fits-all approach, that the type of strategies that work in one community may not work in another because, as I mentioned, those urban versus rural differences or, differences in terms of like people's cultural preferences for diet or nutrition. And, there's so many factors to consider in terms of like leveraging the existing resources because community health centers can't be everything, right? They have to kind of partner with their other agencies within their community and leverage the existing resources that are out there. But I do think that there are some really good examples. Right now, there's a lot of new kind of food as medicine initiatives across the country. There's what they call GUSNIT programs. These are through the CDC to improve access to healthy food items. There's produce prescription programs that are out there as well. There are opportunities for grant funding for some of those programs to do program evaluation, to implement and translate programs into your community. So there's loads of opportunities there. I think that there's also a lot of opportunities in terms of, just kind of like small scale partnerships. I know one of our colleagues here in East Baltimore, the local community health center, had a small grant where they could kind of leverage that to bring farm shares to the health clinics so that people could pick up bags of fresh produce on a regular basis. Another community health center that I had worked with at one point had a community garden and taught nutrition classes. I think, all that to say there's a probably, an untold number of stories out there in terms of what has worked well in communities to not only improve food access, but to also integrate it into people's daily lives in a meaningful way. And that I think that really looks different from one place to another. But the other thing I also want to say is that, often when I talk to low-income households, they're hustling for whatever resources they can get, right? That there's not a really solid safety net for many of these households underneath them. So they're visiting the food pantries, but they're also relying on SNAP, and they still have some gaps in terms of, like not say being able to afford meat or, like they're still kind of hustling to try to make sure that they can get a balanced diet. And so I think that we also have to realize that, yes, there could be some really, really great, kind of gold star programs out there. There also probably will be a lot of other programs that might come and go, but they meet a stopgap need. And it's worth trying anything, I think, at the end of the day, if there's resources for it.
Yeah, just to build on that, I think one of the biggest challenges that health centers face in this space, and there's a variety of services, honestly, and programs that kind of sit in the same category, but there's no reimbursement, so like they're building these programs and they're responding to the needs of their patients in their community, but there are no dollars coming in to support this. It's not a part of their reimbursement. And so they get creative. And you're right. I think I'm so proud to say that health centers are masters at figuring it out, but that cuts both ways because then I think it also gives the impression that they don't need added resources or that, supports are not necessary. And that's quite the opposite. But I was going to say too, this is a space where I find some excitement in the opportunity for ingenuity. Because I think you're right. I think that there are some, models to be designed and rolled out, and so many that we don't necessarily know about. I just yesterday learned about an incredible sort of triangulation of partners and stakeholders in Hawaii, actually, where there were major issues with food insecurity. The cost of food in Hawaii, for a variety of reasons, is quite high. But what happened was that one of the managed care organizations came together with the health centers and with local growers and farmers and basically designed something specific for their community to make sure that food insecurity was addressed. And they built it much the way that SNAP operates, where essentially you have a card and you go and you access, and it's basically a part of any place that you can access food and produce. So basically every grocery store, but it was something that was built locally. And I think it's a great example of the ingenuity that can come out of the partnerships and the different stakeholders understanding what that community needs. And again, that's kind of at the heart of health centers. So, I think the need is huge. And like we said, it's going up. It's not coming down, unfortunately. But I do think this is an area where I have a great deal of hope and optimism and belief that it's an achievable solution. It just requires. It does require some support. I don't think that everyone has to be at the table. I don't think it's, it's just private, or, it's the community CBOs here. Everybody has to be at the table. But we live in a country where this should not be an issue. There is enough. And so I think that's the kind of underlying reality from my perspective. But to that end, maybe can we go back to sort of the role of systemic issues and where you see sort of like, okay, maybe if we addressed this, it would sort of untangle some of the other things. You want to speak to that a little bit?
Yeah. I do think that a lot of this is driven by economic conditions, right? That we know, for example, that rates of food insecurity increase when there's, a recession, for example, or high unemployment. And so, a lot of it comes down to ensuring that there is a stronger economic safety net. I mentioned the minimum wage laws earlier, right? Like, I think that we do need to be more mindful of advocating. I think for me, especially, like, I was a clinician and now I've crossed over into this research world, and often find myself talking about economic policies as if I'm an economist, which I'm not. But the reality is that they matter for health, right? I mean, I think that's the important part, is that we should care deeply about economic policies because they do make a key impact on every aspect of our patients' lives. In terms of not just food insecurity, but think about then the kind of downstream snowballing effect that has in terms of every part of their health. And so I do think that there's a real need to ensure that we strengthen our safety net right now. The social safety net in the United States has really been cut dramatically this year because of the budget reconciliation process. The cuts to SNAP, for example, were dramatic. We're talking about, I think the estimate was $300 billion. It is a large amount of money. And this is an essential program. I mentioned that SNAP Ed programs are closing down around the country. A lot of states will also have to try to provide matching funds, which they've never done before. And so they have not anticipated that in projected budgets. And that will mean that essential services are being cut. There's also new work requirements, meaning that, families with children have to meet work requirements. If you're a parent, right, like I heard you say you're a parent, we both are, childcare is not free, it is not cheap. And if you're a low-income person, you're not going to get the kind of job that is going to cover the childcare that you need for you to work to meet the work requirements for SNAP. Similarly, they moved up the age requirement, meaning that more older adults are now required to meet the work requirements. And they may struggle to do that because of higher rates of disability in those age groups, especially in low-income groups. There's so many challenges right now to SNAP in terms of a real need for advocacy in this space to ensure that these cuts do not become permanent, and that they could be that the work requirements could be rolled back with a future iteration of congressional legislation. The SNAP program is authorized through the Farm Bill, which is still up for debate in Congress. And so there's opportunities for advocacy even now to call for representatives to kind of pay more attention to ensure that SNAP can be funded in the way that it has been in the past, in the way that it's shown to be effective, and in a way that actually meets the needs of people in our communities.
You said something earlier that I don't know that in all the years doing this that I realized that I think SNAP and health centers have in common. And that is that SNAP is not meant to cover all of your needs. It is a supplement to. And I think when it comes to health centers, in a way, I think there's sometimes a misnomer that, oh, it's free. Everybody just walks in and you just get your healthcare for free. It's not. It's not at all. And in fact, I don't care if it's $1 or $100. Our health center patients pay based on their means. And that's part of what the health center does, to figure out, okay, based on your particular situation, this is what you need. Here's what we can do, all of the things. But it's there as the safety net, both of them. It is not the full solution, but it is the safety net. And I think you said too, it's about helping people through a period of time or to get on their feet. Basically it's a hand to keep going. So I bring it up because it's, I think, an important clarifier that sometimes people misunderstand. Well, everything is taken care of. That's not the case. There's still a lot of pieces to this, and people are working. People are doing their best to make sure that everything that they need to keep going is intact. But health centers and SNAP exist to be able to support that. We're getting short on time, but I want to just maybe wrap up with what would you say, in terms of our listeners, what would you say they can do to take a more active role in supporting food insecurity initiatives, sort of food justice, if you will, and access to healthcare for all?
Yeah, it's a great question. I think, we've already highlighted the many kind of on the ground ways that community health centers are already addressing food insecurity. And I think that those are more critical now than ever before. So finding ways of kind of, continuing, strengthening, enhancing those programs is going to be essential. Because, I think in the coming months, people will start to lose SNAP benefits and that they will rely on community-based resources even more. And I also think that community health centers really play a key role in this because they understand what's at stake.
Yeah.
So they have talked to patients. They know what that food insecurity means for their patient in terms of, not being able to eat means that they, a patient with diabetes is likely to go back into the hospital. They can tell those stories in a way that I think is compelling and really empower and elevate the voices of their patients into that policy sphere, right? In terms of advocating for their patients, their communities. And I think that is really powerful right now. That's what Congress needs to hear, is to understand what these budgetary decisions mean for people's daily lives, and that, the health and welfare of America is really at stake. It's not an exaggeration necessarily at this point. And so I think that healthcare providers and community health centers are really in the best position to comment on that because they are seeing the patients who are almost always kind of universally eligible for programs like SNAP and Medicaid that are really under scrutiny right now. And so they understand what that means for their patients and can make a big impact, I think.
Yeah, I couldn't agree with you more. I think it is about telling the story, about putting the human face to the policy decisions that are put in place. But I think telling the story about what can be and some of the incredible models and solutions that are already in place and what more can happen. And I think what that can look like in transforming a community. Again, I go back to that Hawaii model where, listening to what it's done in that community, and literally it's been transformed, and there isn't stigma, it's just somehow they were able to together come up with this solution that's been really, really meaningful and changed the lives of the community members living there. So I couldn't agree with you more. It's about, using your voice, telling the story, identifying the realities of what these policies look like for individuals and I think across communities, but then also how it can be different and the role that I think health centers and others can play in driving that forward. But Laura, it was really great to talk with you. I am so grateful, and I hope we'll have many more conversations and much more work to do together in the future. But thank you for everything that you're doing and for joining us on Community Health Centers Unfiltered today.
Well, thank you for having me. It was lovely meeting you, and I'm so glad you're talking about this important topic. So thanks for this conversation.
I just want to say a big thank you to our guest, Dr. Laura Samuel, today for shedding light on the critical role of food and nutrition in community health. If this conversation resonated with you, consider how you can support efforts to improve food access and nutrition education in your own community. Please remember that healthcare isn't just about medicine, it's also about the whole person, and food is at the heart of that. So be sure to subscribe to Community Health Centers Unfiltered for more conversations like this, and thank you so much for listening. We can't wait to be with you for the next one.